Good afternoon. We are so glad that you are joining us today for our family call. We have team members participating today to respond to any comments during the live stream. For those of you who are new to our family calls or perhaps just now connecting with Family Match, we invite you to learn more about us by following our social media, and we encourage you to check out our website, family-match.org. Family Match is a web-based technology that provides a platform where families who wish to foster and or adopt can connect with child placing agencies and vice versa. In addition to expediting the connection between families and agencies, Family Match serves as a data-driven tool for child welfare professionals to assist them with identifying the most compatible families who can meet the needs of children. So, whether you are a family or agency in foster care and adoption space, we would love for you to continue to get to know us and join us in producing better outcomes for children everywhere.
Hi, welcome. My name is Libby Subkoviak, and I am the family coordinator for Florida. And I also help out with a lot of our other states where we have families now registering nationwide as we have started interstate matching. We're so happy that you are joining us today. If you're tuning in for a training certificate, please email us at training@adoption-share.com and we will get that out to you.
Thank you, Libby. My name is Christina Mangillo, and I'm a part of the Family Match team here. And today I have the pleasure of introducing our guest speaker, Molly Abrokwa. LMFT currently serves as the lead clinical trainer for Georgia Families 360 and is passionate about her work educating youth, caregivers, and providers on mental health and resilience. Molly has gained experience with marketing and training throughout her career, providing training for every company for which she has worked. Her work with the foster care population spans almost 3 decades and has included community work, day treatment, schools, in-home therapy, group homes, and psychiatric hospitals. Molly has extensive public speaking experience and has conducted events across the country. Her areas of training specialty have included anger management, behavior management, depression, and suicide prevention, as well as acute psychiatric illnesses. Always invested in supporting her field, Molly has supervised dozens of therapy interns and is an active professional mentor. And we are so thrilled to have you here today with us, Molly.
Thank you, Christina. I'm so privileged to be here. Thank you for the nice intro. And I hope you like my face because I'm going to keep it on my PowerPoint. Well, thank you guys for having me. Today I'm going to talk about some information that is specific to Georgia about the levels of care that are available for behavioral health for our young people. I'm hoping the information will be helpful to people in other states as well, as every state does have some kind of tiered system for more and more intensive services. But I'm going to speak specifically to Georgia, and hopefully that will benefit others as well. We're going to start at the very lowest level of care and go all the way up to hospitalization. So a little about me. I have worked in every level of care that we're going to talk about today. And so I welcome those questions when you guys get to see this. And I know Christina has some questions for me at the end. I'm open to any questions or feedback, but we're going to go ahead and get started. So the continuum of services goes from least restrictive on the left to most restrictive on the right. And so if this is something that you would like to look back on, I would encourage you to take a screenshot. It is a good summary of all the services, starting with primary care on the left, and of course, going all the way up to that hospital unit on the right. I'm going to pause just a second in case you guys want to capture that. I'm going to divide my presentation into two basic chunks. One is the community-based levels of care. So that's all the things, all the interventions that we can put in place in the home without that child having to be removed from the home, which is, of course, always the goal when it's safe to do so. Then we're going to move to the residential-based levels of care, which is when that child or young person has had to go into a program away from the home. So we're going to start with community-based with the least restrictive. The first level of care is the primary care provider. And a lot of people have said, but Molly, this is about behavioral health, not going and getting checkups. The reason I include this is because we do have a lot of primary care providers for our children who do provide that lower level mental health treatment as well. So we have kiddos who don't have to see a psychiatrist and they may not even have a therapist, but they're maybe getting medication from their primary care doctor. So a primary care doctor, in addition to your other health screenings, can manage some straightforward mental health issues such as depression or ADHD medications, and that's true for adults as well. Now, with children, a lot of times a PCP will say, I'd rather them see a child psychiatrist because a lot of the medications our kids take weren't designed for children, they were designed for adults. And so a lot of PCPs would rather a psychiatrist do that. But if it's pretty straightforward, like depression, anxiety, ADHD, sometimes the primary care doctor will manage that. The other important thing is that a lot of our behavioral health conditions can be misdiagnosed if we miss something physically. So, for example, if a child is having tantrums and it's a kid that's not verbal yet, it could actually be a pain issue. They may have pain somewhere in their body. Ear infections. I've seen kids bang their head on the wall when really what they have is an ear infection. Thyroid imbalances or other nutritional issues can look like depression or anxiety. And so it's really important if you're parenting or caregiving for someone who's having mental health symptoms that you get everything ruled out by the doctor first and make sure there's not a physical cause for that because you wouldn't want to medicate or even worse, consequence or punish something that is a medical condition. And so that's why we always say start with the primary care provider. You also, if you are taking a child to therapy or a psychiatrist or a psychologist, want to make sure the primary care provider is aware of that so that they can make sure the medical records include everything. So psychotherapy is what people usually think of when you talk about therapy, which is you and or the kid or young person sitting down with a therapist. So individual therapy would be a therapist talking to just the child or young person, or there's also family therapy, which would include everyone, who's involved with that child, or group therapy. If there's a group of young people who have maybe the same issue, there may be group therapy, and a lot of schools will offer that with the school counselor as well. Specialties may include things like cognitive behavioral therapy, which looks at the way our thoughts precede our behaviors. So when a young person says, "I did it without thinking," cognitive behavioral therapy would say, "Well, you did think about it. It just went by really quick." So it examines the thoughts. Trauma-focused therapy, dialectical behavioral therapy is used a lot with personality disorders and conduct disorders. And of course, for younger children who may not be able to sit and talk about things, there's play therapy. Now, I can only speak for Georgia Medicaid when I say this because that's who I work with. But we don't reimburse based on the type of therapy being done. So it's kind of up to the therapist if they're in network with the insurance, what type of therapy they want to do. That may be different with other insurance companies, but for Georgia Medicaid, we don't micromanage how they're doing their therapy, like whether they're CBT, DBT, or trauma focused. We just want them to be in network and have the proper credentials. So that's kind of the first line, is seeing a therapist every week or two is usually the first intervention. If you step up and you need a little more support, we have what's called core services. And that is an agency that has a lot of professionals under their umbrella. So they have their own nurse, their own doctor or multiple doctors. They have a therapist or multiple therapists, and they may also offer in-home services that have to be pre-authorized, usually by the insurance, always by Medicaid, but most insurances will. So a core provider is kind of an umbrella. And what would happen there is you would go in and they would do an assessment and they would say, we're recommending that this kid see the psychiatrist every 60 days and a therapist every 2 weeks, or a psychiatrist every month and a therapist every week. They're going to make a recommendation for how much service they think that kid needs, and then they're going to adjust it. So if once every 2 weeks isn't enough, they may suggest let's go to every week. And then they're going to take care of all the authorizations for those services coming into the home. You see here community support individual, that middle bullet point, that's CSI for short. So that is actually a team of behavioral specialists that come into the home or into the school, depending on whether the school allows it in your community, to work directly with that child on behavior management and with the caregivers on behavior management. So they are really looking at getting in the environment where the issues are happening because the kids may not act out when they're at the therapist, right? They may act out at school or home. So if you have CSI, you have someone coming into the home one or two times a week usually, and they're maybe doing behavior charts, or they're giving you as the caregiver pointers on how to manage those behaviors and not feed into them. So that's a little more of an intensive service. Core services are great too because they have a lot of contacts with the communities. So they may have different groups or different resources that you weren't aware of. So just a little bit more support than just going to see a therapist. Should things increase in severity, then we step up to intensive family intervention, which we call IFI for short. And that's intended to improve family functioning by stabilizing the living environment or promoting reunification. So, this is for really significant behavioral issues where, let's say it's a foster care or adoptions, you're looking at either disrupting the placement or disrupting the adoption. So, the behaviors have gotten to the point where, as caregivers, you're just not sure if it's going to continue working. If you would come in for 30 days, the difference between this and CSI is the IFI team also includes a therapist, a licensed therapist. So you have them coming to your home as well, trying to save that placement, trying to preserve that placement. Or if the child is already in the hospital, IFI may come in to help them transition home. And so let's say the child goes away for a week or two to the hospital, an IFI team might be recommended to help you prepare for their return home and help them integrate back into the home. So IFI is pretty intensive. That's why it's called intensive family intervention, because it does involve the whole family. It's face to face, and it's in the home, and it's trying to help that child come back home or not have to leave the home. That team is available 24 hours a day. They have to have some sort of crisis services, and it's a minimum of 3 contacts per week. So again, it's a very intense service. And that's why with Georgia Medicaid, it's only approved 30 days at a time. So they might have it for 90 days, but it's approved for 30 at a time. There are some exclusions for where IFI is not used. So IFI is going to be looking at issues that can be resolved in a 30 to 60 day period, right? So if the primary diagnosis is autism, developmental delays, neurocognitive disorder, or traumatic brain injuries, IFI is not the appropriate service. Why is that? Because none of those things are going to be resolved in 30 to 60 to 90 days, right? So they can have autism or a developmental disability, but it can't be the primary diagnosis. It can't be the main issue because then IFI is not appropriate. So this would be something more like depression, anxiety, conduct disorder, and trying to preserve that placement. So in Georgia, case management is a billable service. So we have case managers at AmeriGroup who help our families and our caregivers and our state partners, maybe the guardians of the kids in state custody, helping them advocate for the individual, connect them to services, and educate them. But if a child has multiple issues, multiple providers, multiple diagnoses, they may need a little extra care management. And so if it's more than the insurance company can really provide, then there is a Medicaid billable service. And there's a couple of agencies in Georgia that can bill for case management. And they're looking at an average of 3 hours a week where they're not doing therapy services, but they're just helping the caregivers get the services in place, acting as a navigator, helping them figure out what's most needed, maybe make appointments. So it's just kind of an extra case manager. Again, we don't use that one a lot because we have our own case management services, but it is something that's Medicaid billable in Georgia now. Something that's pretty common with adults, but not seen a lot with kids, but I want to make sure to cover it because it is a billable service, is intensive outpatient. So this is typically in person, but virtual is sometimes an option. This is 6 or more hours a week. Almost all of that will probably be group therapy. So let's say you're caring for someone who's been in the hospital 3 or 4 times and they just keep relapsing with whether it's behaviors or substance abuse, depression, or suicidal thoughts. Intensive outpatient is something that may be recommended because they're going to be getting a lot more contact than they would if they just go back to therapy. So they'd be seeing a psychiatrist every week. They'd be doing 6 or more hours a week of group therapy, and then they would also be working with you as the caregiver to try to create an environment to support that young person. So intensive outpatient, again, we don't see it a whole lot with kids, but we do see it. It is usually in person, so it depends on your proximity to one of those programs. But again, some of them will do virtual. A step up from that is partial hospitalization. So this is basically that youth is in the hospital Monday through Friday all day long, but they're still sleeping at home. So they're not residential, they're not admitted to where they live there and have a bedroom, but they're getting all of the therapeutic programming for the week, but still living at home. That one is in person only. So again, living near a facility that offers that for children under 18 would be an important part of that. Not used often, but I do want to cover it because it is there and available to some of our youth. So again, they would be there 3 to 6 hours, 5 days a week. So they're basically in the hospital, but not living there. So they're taking advantage of all those groups, all those professionals, therapists, psychiatrists, nurses. They're getting all that care, but still coming home to their home at night with you. The last community-based service is ABA, Applied Behavioral Analysis. Most people at this point have heard of ABA. In Georgia, it has been a Medicaid covered service since 2017. It wasn't before that. And that is therapy specifically for those diagnosed on the autism spectrum. It's shown to improve functioning in academics, independent living skills, and feeding disorders. Able to get ABA, you do have to have a confirmed diagnosis. So, Molly, what's a confirmed diagnosis? That means it can't be just a diagnosis from the family doctor who says they seem autistic. It can't be an emergency room visit where they put autism down as a diagnosis. It has to be standardized instruments have to be used. So, your MD or a PhD, which is a psychologist, they have to use standardized instruments to confirm that the autism spectrum disorder is present. And that's what you would use to qualify that child for ABA. Georgia does have a lot of wait lists for both the testing and the services. So a little heads up on that if you haven't encountered that already. ABA can be as few as 5 hours a week, or some kids get up to 40 hours a week. And the focus is not to make them seem less autistic. The focus should be to increase their communication. So if they're able to speak, it would be increasing their verbal communication. If they're nonverbal, it would be introducing some other type of communication, whether on paper or a board that they can point to, and then to decrease problem behaviors. So anything hygienically, behaviorally, that creates issues, that would be addressed through ABA. What ABA does is they look at the triggers for behaviors, the behaviors, and then what resolves them, and they set up a very specific plan. If you do ABA, the family and the caregivers have to be involved. That's an absolute requirement. So this is not something where you would drop a kid off to get their ABA and then pick them back up. The specialist is going to work with the caregiver, and I know for Georgia Medicaid, that is required for it to even be approved. So if the family is not engaged and participating, then they won't continue to authorize it. So that's all the way up through our community-based levels of care. So then, unfortunately, we know sometimes for safety reasons, a young person has to get treatment outside the home temporarily. And so we're going to look now at the residential or hospital-based levels of care. And there's just two of those. So one of those, here's a chart. I'm going to go back to that other slide. Here's a chart if you want to capture it or look at it for a second. So the two inpatient So if you're inpatient, or CSU means crisis stabilization unit. So that is your short term, 3 to 5 to 7 days, just to get the crisis stabilized and then move you to a lower level of care. So we get a little confused when we talk about mental health, but people will usually understand it if we talk about physical health. So let me compare this to physical health. So let's say I've been to the emergency room a couple times because my um, blood pressure is unsteady. It goes up and down a lot. And I go to the ER and then I come home and then I'm back at the ER and then I come home and then I'm back at the ER. At some point, my doctor may say, you know what, I'm going to put you in the hospital for observation. Okay, that's inpatient. That's inpatient crisis stabilization unit. They're going to put me in there. They're going to do tons of labs. They're going to wake me up every hour to get my vitals. It's going to be really intensive, right? And when I leave there, my blood pressure probably won't be perfect. So you go down to where it says focus on the right. The focus is stabilization and then discharge. So if I'm in the hospital for asthma, diabetes, blood pressure, we know that when I come home, I still have aftercare, right? I still need to take my medications. I'm still diagnosed with asthma or high blood pressure or diabetes, right? That 7 day hospitalization is not going to resolve that. It's going to get me to where I can treat it at home. And that's what inpatient does. That can create some problems or some concerns, I mean, from parents because the kid's been in the hospital 5 days and they're still acting out a little bit or they're talking back. So that short-term stay is not going to resolve all of those problems. It's for stabilization, right? It's to get them back home to where they can see their therapist, their IFE team, their core provider. So if these kids go to CSU, they're not going to come home with all the problems resolved, right? They're going to come home hopefully stabilized and still needing services. So PRTF, which is Psychiatric Residential Treatment Facility, and that's a national designation, so probably have those in every state. That is just a little bit of a longer stay. So when I started working in Georgia, kids were in PRTF for years. Now it's weeks or maybe months. So that is when they've been to the inpatient. They've had several of those short-term hospitalizations and they're coming home and the family's following the discharge plans, but they're still struggling to get this diagnosis and these behaviors under control. That may qualify them for PRTF, which is a little bit of a longer stay. So, psychiatric residential, PRTF for short, is comprehensive mental health treatment. They may have severe emotional disturbances and need treatment that has to be in an inpatient setting. So, that means it's secured. They can't walk in or out. It may be appropriate when other things have been tried and haven't been successful. Next to crisis stabilization, it is the most intensive treatment. They're going to have psychiatric evaluations every week, a lot of assessments. They're going to have all kinds of individual group family therapy. I mean, our kids were in group all day when I worked there. They're going to have consultation with other professionals. So, since it's not safe for them to be treated in the community right then, they may bring other professionals in. So, we had a nurse practitioner that came a few days a week to resolve if any of the kids had urinary tract infections or needed acne treatment. We had a medical professional that would come in. They're also going to get school. So, psychiatric residential PRTFs have their own school programs that are affiliated with the local school system. So, if your child has an IEP, they're going to follow it at the PRTF. They're going to be getting classes. And you may wonder how can they possibly do school when they're in the hospital? But I've seen kids, because they've been kicked out of school so many times, they will actually catch up some grade levels when they're in the psychiatric facility because it's the only time they've sat in school long enough to get work done. So I've seen kids actually gain a couple grade levels in a few months because they're able to sit and do some work. One of the keys to PRTF is discharge planning starts at admission. So it is a treatment service and it is not a placement. So let me say that again. It is a treatment service, not a placement. And because youth used to stay there so long, you will still hear people say, well, they're placed in PRTF. But that's not a thing anymore. And again, to compare it to medical illness, if I've been in and out of the ER with my blood pressure and my doctor puts me in the hospital for a month to try to get it under control, my husband is not going to tell people I live at Piedmont now. He's not going to forward my mail to the hospital. I don't live there, right? I'm admitted there. And that's the same with PRTF. So when we have a young person in residential treatment, that hospital is not their home. It's a treatment facility. And so it's important from the moment they're admitted to start looking at where are they going when they're discharged? Can they return to the same place, or do we need to find alternate arrangements? So the request for PRTF can be done by their current behavioral health provider. So if they have a therapist they've been seeing, they can do the application. Or if they're in a short-term crisis hospitalization, the hospital can do it. So some of our facilities in Georgia, they have crisis units, but they also have PRTF. So if it's this youth's fourth time in our crisis unit, I, as the therapist, might go, maybe I should do a PRTF application so they can get out of this revolving door and get some treatment that's a little longer term. It's really going to focus on their current behaviors. So having a history of aggression will not get a young person into residential treatment. It has to be current. It has to be high acuity. So if you look at this bottom paragraph, if I do a PRTF application and I say they need to be admitted because they've been aggressive at home, that's not enough information. If you look at the following sentence, it says, for the past 3 weeks, child has attacked multiple members in the home with multiple outbursts per day. So what is the aggression? The child has bitten, kicked the mom and siblings, attempted to use a knife on a sibling 2 different times. What have you tried? So the PRTF is going to say, what have you tried? We've increased their medication. That hasn't worked. We increased the therapy. We have the child refusing to meet the therapist, and then the child attacked the therapist. We've had to restrain this child, and we've had to call 911 before. So that is a lot of great information on why this child may need residential, because nothing we're trying in the community has worked, right? We've tried medication, we've tried therapy, we've called 911, we've done restraints, we've called crisis services. None of this is working. And that's how you would kind of make the case that someone may need residential treatment. So the facility will need to know if they're in state custody. So in Georgia, that's DFACS. The DFACS case manager, the medications that they're on or have been on, who's the provider that they've been seeing, biological family information. So the PRTF is not going to just let that kid call everybody. So the guardian is going to say, this is who it's okay for them to call. This is who it's okay to call and check on them. So they're going to control the access that way. Definitely crisis incident information, such as what happened and what were the dates. And then any previous assessment. So if they've already had an IEP, if they already have a psychological or a trauma assessment, you want to include all that information with the application so that they're not repeating things. If they have legal issues, so when I worked in residential, sometimes we would have to transport a kid to court. Or if they've been in the hospital, you would need to give them, this is when they were in the hospital and what for. So treatment history, to get into residential treatment or for a child to be appropriate for residential treatment, we're going to need to know, have they been in the hospital, when and why? And this is a really important, was the aftercare plan followed? So let's say that I am a foster parent and I've got Michelle as my foster daughter. And she went into the hospital and they said, Michelle needs medication and she needs therapy. And I don't fill the prescription, I don't give her the medication, and I'm too busy to take her to therapy. So 2 weeks later, she's back in the hospital. And they say, Michelle needs medication and therapy. And I say, we're too busy to go to therapy. Michelle just needs to act right. When it gets time, if I think Michelle needs residential treatment, her odds of getting accepted are going to go down. Why? Because I haven't followed the discharge plan for what happened before. Now, if Michelle comes home from the hospital and she runs away, that's different. All right. That's not non-compliance. That's another behavior. But if they've had several hospital stays and the aftercare hasn't been done, then their acceptance to residential is going to be really difficult because they're looking at, we haven't tried everything we could have tried. They're going to want to know, have you done CSI? Have you done IFE? Have you done intensive outpatient? How long have they been seeing their therapist? So what have you tried and what didn't work? And why can't this child be treated in the home? Well, she keeps running away and she comes back with knives and drugs, right? That might be a reason that someone can't be treated in the home, right? Because you have other kids you're taking care of as well. So residential is just for those youth who can't be treated in the home because of active issues that are making them unsafe. So we talked about discharge planning. It's very important. If Michelle goes into regular treatment, into residential treatment, and I'm her foster parent, and I know 100% that our home is not appropriate for Michelle anymore, I need to discuss that with the guardian or with the state immediately. We don't want Michelle in the hospital for 2 months thinking she's coming back to my house and then spring it on her on the last day, right? Because then she's going to disrupt and run away or hurt somebody and go right back into the hospital. So we need to be sure from the very beginning that we talk about post-discharge planning. Where is that going to be? If it's not going to be with me, I need to say that at the beginning and not wait for it till it's time for her to come home. So the best outcome is when everyone's on the same page. Why are they in this treatment and where are they going when they come out? And just having consistent communication with the treatment team because that facility is looking to discharge as soon as that child is stable, right? It's not intended to be long term. They don't live there. It's not a placement. So if you're the legal guardian, so if you're maybe an adoptive parent or if you're a state worker and you have guardianship, so it's expected that you give the facility all the information they need, that they're able to contact you if they have they need consent for a certain medication or for a type of treatment. And then as that youth begins to stabilize, the facility is probably going to ask for outings and passes. So either the guardian or the foster family or a family member coming to take them out to lunch and see how they do, coming home for the weekend and then bring them back and see how they do to kind of transition home. So they're not hospital, 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 and then home. So they may ask for outings and passes. And then just presenting concerns and questions. And then AmeriGroup will also stay involved if it's an AmeriGroup member throughout this process. So we have care coordinators assigned to every child in Georgia with foster care or adoption assistance Medicaid. And those care coordinators, we have a special team of them who only manages members who are in PRTF. So they're talking to the facilities every week or sometimes every day. We have rounds where our doctors talk about the admission and discharge dates and we review their clinical progress. We'll also be the ones to notify the guardian of when that stay is scheduled to end. And then identifying behavioral health resources available in their area. So we don't make placement decisions, right? Because we're the Medicaid, we're the insurance, but we can make recommendations as far as, oh, the new home where they're going to stay is in Augusta. We can tell you what psychiatrists and therapists are available in that area. Okay, so we would look at the guardian would tell us where that child is going to discharge to, and we would help make sure that services are in place. This is mostly for providers, but I want families to know about it just in case. So it used to be double billing for if I'm Michelle's therapist, right? Michelle's gone into PRTF, and I'm her therapist. When she gets ready to come home, I can actually go to that facility and do sessions with her to help her transition home. So let's say when Michelle comes home, you're going to have IFI in place. That IFI, someone from that IFI team can actually go up to the hospital, introduce themselves to Michelle, talk to her providers, talk about coming home, and that we have transition units. So those providers can actually come up and assist with the transition by meeting with that child and family before they come home. So that's just kind of an additional Medicaid service that we offer now. So for our providers, and I encourage you to take a picture of this slide. It does have my work phone and my work email. So for our providers, the application for residential treatment and all other paperwork that they would need is all on our website. So they can get all that from us, or they can contact the provider line at AmeriGroup. My name and number is here just in case you have questions that come up after this. If you don't know who your child's care coordinator is, I can certainly assist with that. But I want to make sure that I pause for a moment so that you guys can capture my information.
Molly, thank you. That was some great information. I did have just a couple of questions that maybe you can elaborate on. Uh,
Sure.
One of them was, how can families in one state learn about available care options if they're considering moving or fostering or adopting from another state?
Great question. I think my answer may surprise you though, because with all of the agencies and official channels that people could go through, what I've learned the most from is foster parent support groups and foster parent advocacy groups. So we have someone here in Georgia who started a foster and adoptive parent support group, and it's amazing the information that people share because it's all anecdotal. None of it is, this is what they should do for you. It's like, I live in this region. What will they do to help me? Well, let me tell you what they'll do and let me tell you what they won't do. And so it's a good way to make some connections is looking for advocacy groups or foster and adoptive parent support groups, even on social media or Reddit or whatever you're comfortable with, because it is no holds barred. And I've also learned that if you want information to spread in Georgia, you can do all the newsletters you want, or you can tell a couple of foster parents and it will spread. And so there's always kind of an unofficial network that honestly I would tap into if I were going to need that info.
That's a great reminder, Molly. It's funny when we first brought in our very first foster children, it was 16 years ago, and we just didn't have that level of resource. Felt very lost and wandering around, felt all alone. But you're right, there is so much more resources out there and parent groups and such. So great answer to that. I had one more question. Uh,
Mhm.
can you share an example or a story, of course, keeping it private, that maybe illustrates the difference between care levels and why choosing the right one matters?
Ooh, absolutely. So I'll start with the really intensive one with PRTF, with psych residential. I used to be a clinical director of a PRTF, and there's two big parts. So there's getting the insurance to approve it, that's a hurdle, and then there's finding an appropriate bed. And so if I like we had units for sexually aggressive boys and sexually aggressive girls. So if I've got a unit of sexually aggressive girls and my youngest is 14, I don't care if the insurance will cover it. I'm not admitting a 10-year-old with sexual issues because then you've got a 10-year-old with sexual issues with 14 through 17-year-olds with sexual issues. And so it's really important to find the right fit, even if insurance says we'll cover it, finding the right provider. The other thing that would happen sometimes if someone prematurely, without trying other things, goes into that high level of care, you're exposing maybe a kid who's talking back and being disrespectful to a kid who's stealing police cars and tried to rob a bank. You see what I'm saying? Like you don't want them to go into a treatment level with far more severe behaviors and then they're just picking up, oh, they've never had a suicide attempt before. Now they're talking about suicide or now they're stealing or now they're aggressive. So you want to be careful and you always want to choose the least restrictive possible so that those kiddos aren't being in a situation with much more severe behaviors. Because a residential is going to be looking at conduct disorder, maybe even psychosis, like some really stubborn mental health issues, and you don't want to go to that too fast. But insurance is going to kind of keep that from happening anyway. You have to make a pretty good case. We also want to make sure that we're not making our kids feel like they are the problem that's wrecking the entire family even if it feels that way to the family, if you start off with therapy and family therapy, and so the family is also getting some instruction on how to manage the child, not just sending the kid into a service and saying, please fix that and send them back. And so you're slowly escalating up, and the more you escalate up, the more the family involvement is going to be required. Because even if I resolve all your kids' issues in residential, if they come home to the same home, and the
Mm,
same dynamics and the same triggers, it's just going to set them up for relapse. And so by gradually stepping up the care, it may also help that kiddo not feel like they're the problem because the higher up you go, the more the family will be pulled in.
mm. Well, that's a great answer. Thank you so much for that information.
You can tell that's definitely something that happens.
Yes.
Okay. This one is a hard one. What advice do you give to families whose child gets denied admittance to residential treatment due to extreme behaviors? What options do those parents have if no facility will take them, but it's not safe for the child to remain in the home?
So the facility denied them because of their behaviors?
Yes, the facilities won't, if you have a child who's acting out aggressively sexually, there's a lot, at least in Florida, it can be really hard to find a facility that will take them.
Okay. So that, In Georgia, we have six PRTFs, but they all have different units. So some will treat autism, some will treat sexually aggressive behaviors. So here it would be a matter of finding the program. You're always going to go with safety first. So trying to talk to the guardian about separating maybe that child from younger siblings, maybe not in a different placement, but definitely looking at like sleeping arrangements to try to isolate the chances of something happening sexually or aggressively. And then I would just say getting the most intensive service you can in the home until something residential opens up.
Okay.
So, unfortunately, there is not a good answer to that because, again, the facilities can't take someone who's going to disrupt their whole program,
Right.
but then the family is looking at the same thing. So, it's really a lot of it's about prevention, like getting services in hopefully before it gets that serious. But that doesn't really work when someone's in the throes of it. I've had
Right.
families that have had to resort to disrupting the placement, disrupting the adoption, getting legal involved. So if it's a youth who is purposely doing what they're doing, it may be time to get legal involved, which is always a hard step for parents. But it does
Right.
provide more oversight and maybe even more treatment options. Because I know in Georgia, if they have those legal charges, there's even more services that open up to them. So yeah, there's not a great answer to that one, Libby.
Yeah, unfortunately. Yeah, it's really tough. What advice would you give to parents in general when they say there aren't any available state? Like this has been happening in Florida where they'll say there's not any beds available statewide, and the family's kind of panicked. What do we do? Are they, is there resources to look outside of your state, or what advice would you give to them? Like where would they start?
So I would start with the programs that rejected them because that kid would not be the first kid denied at that placement. So the PRTF where I worked, we actually had contracts with 12 other states where they had nothing for those kids in those states, so they sent them to our place in Georgia because of the specialized units that we had. And so, but then you're like, well, who are we sending? If we could take kids from 12 states, why are we sending kids out of state? Because there may be nothing in Georgia that's appropriate. And so that's where they would start to look at other states. I would start with the facility that denied them and say, well, what recommendations do you know? Where have you sent other kids with these same issues that you couldn't accept, or with your insurance company? Because I know that our team of residential care coordinators, they know who's placed out of state, who went where, and why. So I would say the facility that does the denial, ask what their recommendations are, and then the insurance company that's planning to pay for it, find out if they know of other options out of state.
Okay, that's good. Um, Kind of switching gears a little bit, but what are some practical tips for when a child returns home from being in a residential setting? Like, what are some do's and don'ts to help the child adjust back into family life? I know you mentioned that there are a care team, but what can parents, some practical things parents can do in the home, you know, just to help the transition?
Well, I mean, the first thing would be letting them know that you want them back at home. So if you have the expectation, we haven't done anything to prepare for you, we hope you got fixed at the hospital, is a great way to have them relapse. And so, I said this in one training and I had a parent go, why are you blaming the parents? It's not about blame, it's about everyone adjusting. So if you know anything about trauma and behavioral disorders, you know that even if I'm not doing anything wrong, I can trigger those behaviors. So the entire time that kiddo's in residential treatment, the family should be learning what triggers their episodes. How can we decrease the triggers? What is our safety plan? And then, most importantly, talking to the kid. Because I don't care if they're 6 or 16, ask them, is there anything you liked about the hospital? Is there anything? Well, we had a group every morning where they did a check in. How was your sleep? How are your feelings? And maybe we can do that at breakfast. Hospitals are extremely structured, and that's why kids sometimes get better there. And then they go home and kind of fall apart. They've gotten used to that structure. And so just asking the kid, is there anything they do that you want us to do at home? Or did
Good.
you learn any new skills? How did your therapist work? Oh, my therapist was using this book with me in therapy. Well, can we get that book? And so asking them what helps, asking the hospital, what did y'all do when he or she was starting to escalate? And can you teach us that? So trying to letting them know you want them home and that you're also committed to making this work, not just expecting them to come home healed. Because again, if I'm in the hospital for asthma, nobody expects me to not have asthma anymore when I come home. So if
Right,
I'm in the hospital for bipolar, don't expect them to come home and not act bipolar anymore.
right.
Right.
That's good. Thank you. That was it for me.
So, Molly, thank you so, so much for joining us today. We really appreciate all the wisdom that you brought. And if you're one of our regular Family Match families, please keep an eye on your emails for any upcoming trainings or any other helpful information. If you have any questions, please reach out to us. We look forward to hearing from you. Molly, thank you so much again.
Wonderful. Thanks for having me.